Hello, and welcome back to the second session in a two-part conversation titled The Opioid Epidemic, a Statewide Response. I'm John Stemmel, Professor of Strategic Communication at the University of Missouri School of Journalism. In our first conversation, we UM system faculty provided context on the current state of the national struggle with opioid addiction. In this second session, we've gathered experts to discuss some of the work being done across our state in response to this pressing need. Like last time, all of our panelists will be available for additional conversation in separate breakout rooms following our time together. Please join me in welcoming Dr. Casey Burton, Director of Medical Research at Phelps Health in Rolla, Chiquita Shanae, Community Health Outreach Specialist with MU Extension, Chad Sabura, Executive Director of the Missouri Network for Harm Reduction Support and Reform, and Dr. Heather Lyons-Burney, Clinical Associate Professor at the UMKC School of Pharmacy, Springfield campus. Thank you all for joining us today. Chad, I want to start with you. The Missouri Network is tackling this issue from a variety of fronts, and I want to dive deeper into your legislative work later in the program. But can you start us off by talking about the needs of someone in the early stages of recovery and what services the Missouri Network offers to those individuals?
Well, Mo Network sees recovery not as an absolute definition, but as it is, which is stages of change, and also recognizes that substance use disorder, just like any other mental health disorder, does exist on a spectrum. So the engagement is individualized, and we identify individuals that are in a stage of change of recovery who might still be in a period of use. So we need recovery supportive services and life-saving interventions at all those stages. So some of those early engagements are going to be access to syringe service programs, education about overdose prevention, early stage of recovery. We're going to need recovery supportive housing, recovery supportive workplace, making sure that individuals have a sober social support network that fits their philosophical belief system, and they're not forced into a cookie cutter type of scenario. So it's a great question, but it's so many little intricate details there that it's so individualized. We need supportive services at every point of the spectrum. And then if we're looking at the absolute definition of recovery, we definitely need to ensure housing and employment, and make sure that the core issue, which is typically mental health root cause or trauma, is being properly addressed clinically.
Thank you, Chad. I'd like to move on to Dr. Lyons-Burney. One of the things that you and Chad have in common is your support of the drug Naloxone, which has its own share of controversy. Can you share information about exactly what this drug is and why, as a pharmacist, you support it?
Sure. To Chad's point, opioid overdose prevention is key. Naloxone, or commonly known as Narcan, has really been around for decades. We've used it in emergency rooms to prevent opioid overdose or to reverse opioid overdose. So all Naloxone does is knock that opioid off that receptor so that we avoid those overdose symptoms, such as the respiratory depression, the extreme drowsiness, and those things that could potentially lead to death. Luckily, in Missouri and most any state in the United States, we are able to access Naloxone without a prescription through the pharmacist. So your pharmacist could help you decide which form of Naloxone is best for you. And the way we like to think about it, and really the general public can think about it and how we encourage it to be used, is like any other emergency medicine. So that EpiPen, if you have an allergic reaction to something, that glucagon pen, if you are someone with insulin that has low blood sugar. So think about it in that vein. It really is a tool that helps us prevent opioid overdose death and give that person a chance for recovery and for whatever else comes in their life.
So one follow-up on that. We've heard a lot about the pharmaceutical industry. What do you see of the pharmaceutical community in this crisis, and what initiatives are now underway to address this issue?
Yes, so it's been coming, obviously for the past probably good decade or more that we have recognized that pain management is key and that opioids are ones that can become to where we can develop an opioid use disorder or a substance use disorder fairly easy with those. And so we are starting to look even harder at alternatives for pain management. So looking at it a lot more holistically, what are we doing to manage pain better? The other thing that we're really working on as a healthcare community is team-based care. So how do we integrate pharmacists, providers, chiropractors, everyone in pain management, and how do we treat that patient better so that that patient can manage that pain in a more efficient way? The other things that we look at are just like naloxone. If we have to send someone home with an opioid, and they have certain risk factors, and it may not just even be the fact that I'm worried about them becoming an addict, but really if someone has lung issues, I don't want to give them an opioid because that's dangerous. And so who are these people that we need to give naloxone to? As well as for the first time, luckily in Missouri, we have what's known as a prescription drug monitoring program, which is a terrific tool in the toolbox of healthcare professionals in looking at a patient's history. If someone were to go to the dentist and then maybe their orthopedic surgeon or the emergency department and get prescribed 3 different opioids or other medications that could cause some harm, we could see that now. We weren't able to do that across the state, but now we're going to be able to do that, which is super exciting. So again, kind of multifactorial. There's not one thing that we're doing that is just the ticket and the key, but there's a lot of different things that we can do as a healthcare community to make pain management more efficient and make it safer for our patients.
Thank you. Dr. Burton, I'd like to turn to you now. We heard a little bit in our last session about the struggles that rural communities are having in combating this issue. I'd like to hear directly from you, though, what initiatives are underway within the medical community, and then what's working and what roadblocks are you encountering?
John, that's a great question. As we heard in the last session, the opioid epidemic here in Missouri, as it exists today, has become less of a prescription drug problem than an illicit drug problem. The medical community today is far more cognizant of its prescription practices than even just a few years ago, aided largely by evidence-based guidance. So for example, the average number of opioid prescriptions here in Missouri has fallen from about 80 prescriptions per 100 people back in 2016 to about 54 prescriptions per 100 people just last year. And the rest of the nation has followed that trend. And it's not just the number of prescriptions that are going down, but also the mean day supply and dosages. And as Heather just mentioned, with the establishment of a prescription drug monitoring program, we do have new tools to help identify patients at risk of being overprescribed, as well as medical professionals who may be overprescribing. And that's the good news. Of course, the bad news is we continue to see steadily increasing mortality associated with opioids and other substances, especially in economically disadvantaged areas, including many rural communities. We are seeing an increase in the use of opioids and other substances like heroin and fentanyl that tend to be more potent, affordable, and ultimately accessible than many prescription opioids. So in this way, the current opportunities and challenges lie in developing effective prevention and treatment models. However, rural communities often lack the resources, not to mention, transportation barriers, health literacy barriers, and other economic barriers to develop these specialized care services compared to some of their metropolitan counterparts. Down here in Rolla, like many smaller communities, we have built community coalitions by partnering with a number of local treatment centers, law enforcement, the criminal justice system, not to mention the university, to identify new collaborative models to leverage some of these existing resources and capabilities. And a major focus of those efforts has been on the detection and identification of at-risk patients, and then appropriate referral to some of these specialized services. I'm definitely hopeful that we'll see outcomes from this model and others like it being developed elsewhere to evolve into new evidence-based community interventions to help address this problem.
Well, we know the community-based, especially when the community can get involved and take ownership, it's definitely much more powerful and viable as an action. So to follow up on that, Dr. Burton, can you share information on how the medical community has changed its practices on prescribing drugs and helping patients deal with pain in light of the opioid crisis?
John, that's another great question. You know, beyond some of the policy changes and guidance we just talked about, like, you know, the prescription drug monitoring programs and new prescription guidance, the medical community itself is also looking at non-opioid treatment protocols. So just setting aside chronic pain management for a moment, you know, one of those alternatives I'd like to highlight is enhanced recovery after surgery, or ERAS for short. So opioids continue to be a mainstay for controlling pain after surgery, but of course, opioid medication can come with some side effects, you know, beyond the addictive potential that can adversely impact post-operative outcomes. So enhanced recovery after surgery protocols tend to use a variety of non-opioid systemic therapies, as well as, you know, regional and neuriaxial techniques that can provide effective pain control, all while reducing opioid use. So for example, we've developed a number of ERAS techniques down here in Rolla, ranging from breast mastectomies to total knee replacements, to labor and delivery in high-risk moms. And we've seen drastic reductions in the amount of opioids consumed, both during and after surgery. In addition, through better training and awareness of the unique needs of patients with pain, the medical community has taken an active role in urging policymakers to remove barriers to care, with an emphasis on reducing healthcare disparities. This includes removing barriers to prescribing medications to treat opioid use disorders, barriers to making non-opioid pain care alternatives both more accessible and affordable, but also barriers to individualized patient care decision-making over some of the more arbitrary thresholds set by current guidance. So in short, the medical community is well aware of the substance use epidemic we are facing and has recognized the various roles it can play in mitigating this challenge.
Thank you. I'd like to now turn to Chiquita Cheney. So you're the leading community health and outreach initiative for MU Extension and are working in many communities around the state. Talk to us about the program and the work that you're undertaking.
Yes, thanks for having me here today. I am the principal investigator for the Rural Opioids Technical Assistance Grant that's funded by SAMHSA. But I'm also the community health outreach specialist for MU Extension's new program area, Community Health Engagement and Outreach. So basically, we are working across extension programs in partnership with labor workforce development. And this work is an example of an interdisciplinary approach to working at the intersection of substance use disorder and workforce development. And our program is working to create recovery-friendly workplaces. So I'll explain what recovery-friendly workplaces are. They foster a culture that promotes employee safety, health, and well-being through strategies that include recovery resources, but also providing support. And we're hoping that we can reduce stigma to the challenges that are surrounding substance use disorders. It allows us to work upstream to address social determinants of health. And of course, with the pandemic, all of the implications of the pandemic have been really impacting us, and substance use disorders have been magnified. So earlier this year, we worked with Dr. Mark White And he helped us to explore how addiction has really impacted our state's economy. And so the Missouri economy loses an estimated of 14,744 total jobs each year, of which 5,518 are direct losses, 4,801 are indirect, and then 4,425 are induced due to opioid-related losses of the state's manufacturing workforce. But then when we look at healthcare workforce, there's an estimated loss of 15,243 total jobs, of which 9,000 of those are direct, 2,400 of those are indirect, and then 3,000 are induced because of opioid-related losses. So for every 10 manufacturing jobs lost due to opioid disorder, 16.7 jobs are lost elsewhere in the state's economy. So we're losing a total of $854 million in labor income and $1.17 billion in value added, which is a total of $2 billion in output. So with this program, we're hoping that we can create training and education that is responsive to this issue and present opportunities for businesses and employers to reimagine how we can support our workforce by creating supportive, healthy work environments.
Wow, those numbers are really eye-opening. I would like to ask you something else about the work that you're doing. We know that overcoming addiction is a long process. And one of the biggest struggles for someone is finding employment after a drug conviction while still in recovery, which you just talked about briefly. Can you share a bit more information on the supportive employment work that MU Extension is doing?
Well, I will say, John, it's not so much as supportive employment work, but it's more interdisciplinary work. So now, while this grant is leveraged by the University of Missouri, it is a statewide effort, a collaborative effort. So we've had and we've also had an overwhelming response. With the opioid crisis and the pandemic, our mental fragility has led us to think that we really need to have these conversations. And so and respond to the needs of the workforce. And when we first started working in this space, we researched many states to better understand their approach and what type of challenges and opportunities came as a result. And so we're hoping that with this partnership with the Missouri Hospital Association, the Missouri Rural Health Association, and Missouri Chamber, that we can have some discussions and find out what the needs are and address them through training opportunities. We're wanting to work with all type of organizations, all sizes, and all at all levels of readiness. So we recently conducted a Chamber of Commerce survey to businesses across the state to help inform our work. And what we found was that 71% of respondents report consequences due to drug misuse, including 49% respondents reported absenteeism, 38% had decreased productivity, and 19% report accidents. So the most common substances selected by employers as a threat to their workforce is prescription pain medication and alcohol. Let's not forget alcohol. And so, with this work, we're hoping that we can have opportunities through training and education to really address the needs of businesses and give those businesses the tools they need to retain a healthier and more productive, more motivated workforce through the delivery of evidence-based safety programs and practices. And I want to shout out Dr. Marshall Stewart for providing us the inspiration to this work across extension programs by addressing the 3 grand challenges of health, economy, and education. You can learn more by going to our website, which is recoveryfriendlymo.com.
That's fantastic. So, Chad, I want to come back to you now. We've talked about some of the short and long-term supports and responses that are in place across the state that respond to the opioid crisis on an individual and collective level. One of the largest undertakings of the Missouri Network is looking at underlying legislative policy that is in place around this issue. Why is this such an important approach in the overall solution?
This is where I will be a voice of somewhat of disagreement with some things that were said. This is all rooted in United States drug policy. So we got here through over 100, close to 150 years, because it started with the China Exclusion Act as our first active, true drug policy war on drugs, systemic racism against Chinese immigrants. And it's always had the same general principles, which are not rooted in data, which is prohibition, arrest, criminalization, and the complete unwillingness to launch evidence-based harm reduction services, such as fully supported syringe service programs, safe injection sites, access to a safe supply, and the list is absolutely endless. So we look at things like PDMP, and we can see the benefits, but we can also see that the enforcement and prohibition of painkillers drove many people from painkillers to the black market for heroin. Then we saw our heroin death spike after that happened in 2010. Increased enforcement on heroin invited illicit fentanyl analogs into the market. There is no heroin. It's all fentanyl analogs, roughly 27. So as we continue down this path, if we don't make massive corrective action to all of these things that had led us up to here, we're going to be here in 5 years, 10 years. The numbers will keep rising because we're not addressing the underlying root causes: trauma, poverty, mental health, lack of access to basic healthcare needs. And, you know, the numbers of individuals who were induced into heroin opioid use disorder through prescription painkillers is much lower than what is reported in the most reported study. So there's so many other things that are happening right now. And we do know that a report came out 3 weeks ago showing the massive increase in overdose deaths. And then, you know, the CDC started backpedaling on their 2016 prescribing guidelines because we've seen a 23% rise in suicide among chronic pain patients for lack of access to medication. And we're not seeing any decrease in opioid use or overdose mortality. So access to a safe supply and addressing all those issues, and finally embracing data, evidence-based harm reduction services, which every other country does but us, is the most important factor. It's what's going to turn the tide here. There will be nothing else that will shift things unless we do those things.
Thanks, Chad. I'm glad that we're hearing about social determinants of health so much in this conversation, because it is critical to this issue. I did want to bring up, you're very open with the fact that you're also a recovering addict. What advice would you give to someone who's currently suffering from addiction that hasn't sought out help yet?
Well, I would like to focus on person-first language, because addict is just a word that we don't use anymore. And you know, we won't tell people how to self-identify, you know, themselves in recovery settings, but you know, just the use of an illicit substance alone does not clinically qualify somebody to have an SUD. And there's a lot of stigma when it comes with just that word alone, because you know, every other mental health disorder, person-first language. A person with substance use disorder. You know, I'm not defined by my addiction, and I would not be true to myself if I gave an answer, because everybody's an individual. If somebody hasn't sought help yet, you know, the most important thing to do is to make sure that they're engaged with access to services with no expectations or requirements they arrest their drug use. That's one of the hugest deterrents right now, because many of the things we refuse to treat, mental health issues, hepatitis C, housing, employment, they're the cause of the drug use. So we can't expect them to arrest the drug use when we haven't removed the cause. So we have to engage them into a harm reduction program, which does exactly that, can provide them clean syringes, can provide them naloxone, resources that other people won't, because of that philosophical approach that we have towards people who use drugs. So that's what I would tell them. And there are 4 rules, you know, to follow to prevent overdose deaths. You know, never use alone. Well, I'll just do the big 2. Never use alone. Always carry naloxone. We have an 800 number that took a lot of work. It's a national hotline we built called neverusealone.com. So if you do find yourself alone and you're going to use, call that number. The person on there is non-judgmental. They're in recovery themselves, and they'll stay on the phone with you. And if you go unresponsive, they will call 911, and you cannot get arrested based on Missouri's 9/11 Good Samaritan law from that scenario. I wrote the law, so I can say that confidently. And then also to always carry naloxone. If you don't have access, like some of the major cities do, we have another website called nextdistro.org, which is a mail-based delivery service. Fill out the form, and we mail you naloxone. If you ordered it from Missouri or any of the 8 local states near us, I send out packages every Friday. So follow those rules, do those 2 things. Nobody dies today. And we have to make sure that we get that message in across. So I would tell an individual that is, still using that, there's a different way that we can treat them with dignity, with like a human being. The more we empower somebody, the more they're going to have a self-directed will to seek recovery. The more we use stigmatizing terms and cut off access to medication because they're smoking weed, so they get kicked out of the methadone program. The more we do this, the more we just have all these barriers in place, the more people will die. We have to get rid of those barriers and welcome people into our care with no expectations except don't die today.
Thanks, Chad. That's a lot of great information and perspective, I think, for all of our attendees today. So we are now going to look at some of the questions that have come in from those joining us today. And I wanted to start by going to Dr. Lyons-Burney. The question came in, you mentioned a prescription monitoring program that's now in place in Missouri. Does this database reach across state lines? Thinking about how our largest population centers straddle state lines.
Yes, that's a good question. And really to just echo Chad's point, as well as the points that everyone's made, is it really is a multifactorial approach. The PDMP is and never will be the be all end all, but it does serve as a useful tool. I wish we would have had the PDMP when we really started seeing the opioid rise in our state, and then potentially we could have identified some patients that we saw going down the wrong path, but we didn't. But now we do, and so for that, I'm entirely grateful. I border on the south side of Missouri into Arkansas. And so luckily the software that we have in our state that we started with out of St. Louis County is able to look at other states' data. So we can see if we have a patient that has kind of a dangerous combination of medications, or if we see behavior where we, as providers, as pharmacists, need to ask those questions of that patient. And that is one thing that we are really working hard to do within the pharmacy school, for example, is train up our students and our providers to ask those questions of the patients, to look for those risk factors, and to identify patients, hopefully before they go down that path. And so prevention is key. PDMP is just one of those tools for prevention as well. So that was a long answer, but yes.
So I want to, that's speaking to the side from service provider for somebody who's receiving medication. I'm going to speak from the streets. Right now, our illicit black market is flooded with pressed pills. There's a pill press right across the river in Illinois that's pumping out 3,000 pills a week. That's they are scored to look like Oxycontin 30s, but they're actually fentanyl with a bunch of other cuts. So if we look at this from the saving life standpoint, what would we want on the black market that somebody's going to buy? Would we want these pressed pills, or would we want the actual Oxycontin that people think they're buying? Just something to think about when we think about that person that's never had an opioid, that doesn't have a tolerance, that is just trying a pill for the first time at 16, which almost everybody has. What would we want them putting inside their bodies? The answer would be nothing. I get that, but we have to look at reality. Do we want a diverted actual pain pill, or do we want a pressed fentanyl pill that has zero cutting what's the word I'm looking for? There's no proportion in the cut. It's all different. It's very deadly. So ask yourself that question sometimes. What would you prefer somebody buying?
So Chad, I wanted to ask you about another question that just came in. How do we work? You talked a lot about stigma related to opioids and other substances. How do we work to break down that stigma that you did mention? How do you respectfully have those conversations with people about using person-first language and the mental health aspects of the language when all they see is stigma?
It's generational. The stigma associated with substance use goes back to the temperance movement and all the propaganda they used in the 1880s. So all of us have this Jungian collective unconscious that was like subjected to us through our great grandparents. So we have to start to shift. We're not going to see it in our lifetime. Hopefully, our great grandkids will look at this differently. And lobotomy was used for mental health disorders. The R word was used for many mental health disorders in the 50s. We never see that anymore these days. It's going to be the same kind of transformation here. So I wouldn't suggest doing it politely when it comes to these conversations. Obviously, be polite, but there's no like backing down or like compromising how we talk about people who use drugs. And we have to be strong there to set the foundation for the next generations to continue.
Thank you. I'd like to turn to Dr. Burton for this question. Do you feel Big Pharma targets rural communities for increased distribution of opioids due to the stereotype that individuals living in these communities are less educated and have less access to resources?
John, that's an interesting question. Even if there were targeting in place, just based on some of the clinical guidance, PDMP, some of the structures we have built over the past 10 or so years, it's actually quite difficult to overprescribe in today's environment. I'm not saying it's a perfect system by any means, but just based on these thresholds, prescribing thresholds, it is more difficult today than it was 5 or 10 years ago to overprescribe a given individual. And again, that's reflected in the data due to these decreases in overall number of prescriptions being made, but also just the dosages and the total length of that duration. So as long as we continue to see those numbers decline, I would say there's probably not a targeting campaign, if you will.
Thank you. Another question came in, and I'll open this up to the group. Is there a proverbial log damming the river that if we were able to address it, would rapidly allow progress on this issue, or is it more a collection of smaller issues all combining together?
Which part? I mean, there's so much to log. If we flooded the black market right now with black tar heroin, death rates would go down. If we instituted universal health care, we would slowly see mental health issues diminish generationally. So but there's so many facets that we can look at. What can we do in this area in order to make massive improvement immediately? Gabor Matt, in the realm of hungry ghosts, adverse childhood experiences, mental health, trauma, growing up in poverty is one of the biggest precursors to substance use disorder. So eradicating poverty, can we do that? These are big asks to log this dam. Right now, it's damage control, in my opinion, from the past 150 years of flooding communities with naloxone, because your true first responder, and this is based on federal data, is the other person using drugs with them, or a community or family member, not anybody engaged in that first responder role, law enforcement, EMS. It's drug users and community members. Flooding communities with naloxone, creating safe spaces on many levels, safe spaces to use and safe spaces for people to go, recognizing the exclusion of BIPOC communities and people from the LGBTQI plus communities who have had generational trauma as well, especially the trans community, who will not seek your traditional route for help because of what they have experienced. So there's so much like holes in the dam that I could go on, till tomorrow, and you guys would tell me to shut up.
Yeah, Chiquita, I see your hand up.
Yeah, I was just gonna add to what Chad's been saying. Let's not forget the stigma that's been associated with the use of stimulant drugs over the years and all of the stigma that was created, decades ago. As a matter of fact, I've been impacted indirectly and more directly by the use of substances, particularly when the crack epidemic took place in the early 80s and the 90s. I was impacted. My mother struggled with addiction for many years. And, while she functioned and was able to go to work every day, it was still a challenge. And that impacted my family. It impacted me. It traumatized me, as a matter of fact. I've been blessed that it hadn't impacted me in my adult life, but, it's been the inspiration for the work that I'm doing. And so, we also need to think about applying a health equity lens to be sure that we're reaching all communities and all people of different backgrounds and demographics in order to be equitable in the distribution of care.
I add one thing to, sorry.
And also people should be keeping in mind that, when it comes to recovery, it's not just, okay, I'm in recovery today. I may be in recovery today, but next week I may relapse. So what type of things do we have in place to support people who relapse? And so we're hoping that with the program that we're creating, that we'll be able to reduce stigma as it relates to recovery and also having employers to better understand what that process might look like. And so that it's a long-term supportive effort.
And just to piggyback real quick, while we're talking about opioids, we're still fighting in DC to remove the sentencing disparity created by Reagan's Anti-Drug Abuse Act of '86, was the 100-to-1 disparity for crack and powder cocaine. Eric Holder, when he was AG, we got it down to 17-to-1. We have the Equal Act right now going through Congress. So while we're talking about opioids, we're still fighting the systemic racist policies from 1986 today. Now, that's a statement in itself.
Dr. Lyons-Burney? Oh, sorry. Dr. Lyons-Burney, I know you had wanted to chime in on this as well.
Yeah, great conversation. I was just going to add in there too. I think having these conversations is great, and just raising that community awareness. What are these terms? It is a mental health disorder. How do we address it? And then getting the community involved through prevention. And so, those county coalitions. So it's not just healthcare professionals. It's not just people in offices or people that have come from recovery. It's families that are impacted. I see it every day in my primary care office practice, the repercussions of it. I'm treating patients with hepatitis C every single day because of that. They're doing awesome, and they're awesome people. So I think just, having these conversations and raising this awareness, it's treatable. And so we just all need to get on board to be able to do that.
Dr. Burke?
Yeah, no, I would just second. This is a multifactorial problem, as we've heard all morning. There's a lot of low-hanging fruit and high-hanging fruit. But speaking from the rural perspective, one thing I would emphasize would be, mental health services. We see a lack of access to mental health services across rural Missouri. As Chad mentioned, there's trauma, there are these generational issues, and just a general lack of resources. So if I had to pick one thing, that would be my top pick.
And Chiquita, back to you.
Yeah, Dr. Burton basically took the words out of my mouth. I was going to say it's multidimensional, it's multi-generational. It's something that, communities really need to be involved in. Businesses need to. It's really impacting people with the businesses and also our economy. So we really need to join together. If we have our communities to join in this process, it will be more sustainable because they are more invested in seeing what the outcomes will be.
So Chiquita, I'd like to stay with you for the next question. What advice would you give a small business owner who only has a few employees that wants to build a supportive workplace for employees that may be suffering for addiction?
That's a great question. Well, the first thing I would suggest is that, they connect with us. They can even go to our website, recoveryfriendlymo.com. We're building some education and training. We worked with an organization called Shatterproof, who has developed like some little short educational modules that introduce the idea of addiction. I think that the more that employers understand that addiction is a brain disease, that's a good place for them to start, by understanding that and understanding what needs to take place or what type of supports need to be in place for a person to sustain their recovery, could help to benefit them. We understand that a lot of employers, especially small businesses with only a few people, they may or may not offer health insurance. So there are other resources out here that can support people through this process.
Thank you. Another question for the group. When addiction hits your family, how do you balance between being supportive and being an enabler?
Wow, that's a very interesting question. Well, it's very difficult to balance that. I can speak from my own personal experience trying to support my mother through her process of becoming to get to recovery. It really hurts, but self-care is important. That's what I would suggest, is making sure that you put your needs because how can you help a person when you're struggling yourself? There are Al-Anon and other support groups that help people to be supportive to their families.
Enabling. I think it's blanket phrase that we throw around there instead of doing a deep dive into the individual. Because if you have a loved one struggling with substance use, you have trauma. You have been gaslit. You have had lots of things happen to you, that it's not a black and white thing. And individualized care on every level here is very important. That includes family members, because they have to recognize their own toxic behavior, learn how to establish and hold healthy boundaries, while at the same time providing a safe space for their loved one, that does not cross those boundaries. So when I don't like the whole, okay, go to this, meeting where everyone's going to tell you the same thing, because look at our mortality data. What we're doing right now isn't working. So we need to engage family members and also education about harm reduction, education about what's going on in the black market, education about themselves. And we have to stop making the assumption that because a family member is sick or has a mental health illness, then the rest of the family is also sick, because we tell people you're sick because, and it's very dismissive of somebody's own personal journey when we don't take the extra 20 minutes to talk to a family member. And instead we just throw these terms at them that we just say because other people said them, because 50 years ago, we didn't have billable codes with insurance companies to treat family members. So there's a lot of history there as to why family members aren't given that specialized, unique care that they deserve, because they also have to go through their own healing process through this.
And John, just to add on to that, we heard a little bit in the last session about the educational partnership we have formed with Dr. Claire Cooney at Missouri S&T. And two of the findings of the community survey that I think really speak to this question is that a high number of respondents either had a friend or a family member who was currently suffering some sort of substance use disorder. But the other interesting finding was just the general lack of awareness of existing resources throughout the community and the region. So part of that is really just building the community awareness of what resources exist. So if someone does have a friend or a loved one who may be suffering, just knowing who they can turn to for that sort of care.
Thank you all. That was a great way to wrap up that part of the Q&A. However, I'd like to end our time together with a call to action. I'd like to give each of our panelists the opportunity to share their personal recommendations for how those gathered here today can get involved in this work to help address the crisis. I think we're going to go a little, maybe we'll do some Brady Bunch action here. We'll start with Dr. Burton. You're in the upper left-hand corner for me, so we'll start with you.
Yeah, no, I would echo Marshall's call to action this morning, and we have such a great resource in the form of university extension that really spreads across the state. We have representatives in every county. I think that would be a good first stop to see what is going on in every single community. Those representatives, in my knowledge, are very knowledgeable about what resources currently exist, what challenges may be unique to that community. So stop by your local extension office and see what's going on in your community.
Dr. Lyons-Burney, let's move to you next.
Right. And just to echo Dr. Burton, yeah, find out what's happening within your community, get involved either through MU Extension or again, your county coalitions through CADCA, which is the National Organization of County Coalitions, are really meant to be grassroots efforts. You can educate yourself on naloxone, how to use it, when to use it, how to carry it. You can educate yourself to be a prevention, part of a prevention specialist. There's evidence-based trainings that you can take to community. You can take it to the middle school and provide those for students. So just educating yourself, raising that awareness, being aware and being that resource for your community and your family.
Chiquita.
Yes, I would just like to echo what the other speakers have already stated. Yes, we have extension faculty and staff all across the state where we have a statewide presence. Someone is in every county working with rural community opioid response program grantees. They have funding that they are addressing the rural needs of our communities as it relates to opioids and other substances. Working with those local coalitions, other local coalitions as well, and taking some ownership yourself and being involved. That's going to be the way to sustain this work.
And Chad, let's finish up with you.
To say that this country is divided right now would obviously be an understatement. However, I would ask people to put aside their political belief systems and look at the evidence. Look at the data of why drug laws were passed in the United States. Look at what populations were most devastated by those laws. And then look at other countries and look at the initiatives they have started and look at the data. Look to Switzerland, the pioneers of everything drug policy, and to end with harm reduction services, the main three being syringe service programs, access to naloxone, and safe injection sites. You know, there's a lot of negative stigma around those three services. Now, consequences. Sometimes they are that spark that somebody will use to seek recovery, not always. The only consequences removed by all of these services are death and disease. All the other stuff is in place. So please be open-minded when you look at that and understand that somebody injecting with a medical staff, with counselors, with support, compared to a McDonald's bathroom, that doesn't change what's going on internally with them. That just makes sure they don't die. If you've ever been to a bar and had a beer, you've been to a safe consumption site. Don't let DEA scheduling guidelines dictate somebody else's morality or how you view their worth as a human being.
Thank you. And I'd like to thank all of our panelists for today. Just great information, amazing job. I would be remiss if I did not do my responsibility as the moderator by getting into a few housekeeping items. First, I want everyone who is participating today to know that you can provide feedback on this and all the other sessions via the event survey on the attendee hub. Also, a quick reminder that right after our breakout sessions, everyone will have a 1 hour break for lunch. Let's see, once we're done with the lunch break, everyone hopefully will return at 1 p.m. to hear a panel of experts from across the University of Missouri system and state discuss the health strategies for rural Missouri. And this session at 1 o'clock is going to feature an important discussion hosted by Missouri Farm Bureau President Garrett Hawkins, moderated by Brock Slabaugh with the National Rural Health Association. So with that, I am going to encourage everyone to join the breakout sessions. And one note, Dr. Burton is only available for a very short period of time. So show up early, show up often into his session. And until then, I'm John Stemmel. Thank you for your time today in this critical conversation, and take care.